Okay, Assalamu alaikum. I hope you all are fine and enjoying your holidays, rather holidays with your studies, and hope your family members, your elders and youngers all are fine. Okay, so today we have a new topic, that is, you must have seen a lot of patients in dialysis room on uh, dialysis with other complication of long-standing diabetes, hypertension, or other chronic renal diseases leading to treatment which kidneys are unable to offer, and they are on some uh, treatment, which means the kidney has replaced the other modalities. That is when we call your kidneys are non-functional, and you have to put the patient on some renal replacement therapy. Like you have a dialysis machine, just like a filter with the blood going from one side through a filter and it coming to the other side with the removal of all weights, your urea, creatinine, electrolyte balance, and sometimes if you need to remove the body fluid by some ultrafiltration, you can remove the excess fluid which has been accumulated in the body because of renal failure. So we'll discuss in detail what are the options once a patient has renal failure, he has got end-stage renal disease, and he is unable to maintain his renal functions like fluid and electrolyte balance, acid-base status of the body. There are some endocrine functions of the body like erythropoietins being produced from the kidney, and once you have a renal failure, so it can lead to loss of erythropoietin and leading to anemia. And you have seen a lot of patients on dialysis or end-stage renal disease. They are subcutaneous interferon like 4,000 to 2,000 units per week because their bone marrow does not respond unless they have a erythropoietin which is being secreted by the kidneys. Another function of the kidneys is hydroxylation of the vitamin D. So first hydroxylation takes place in the kidney, skin, second in the liver, and third hydroxylation of cholecalciferol, that is the active form of vitamin D being activated in the kidneys. So that's why your vitamin D activation doesn't take place, and you have a renal osteodystrophy, means that your bones become weak, and patient can have renal bone disease because of renal failure. So there are different functions of the kidneys which have to be replaced once they are non-functional. So one of these replacement treatment we have is either in the form of dialysis, whether it is peritoneal dialysis, hemodialysis, or some other options like renal transplantation. So by definition, renal replacement therapy is a therapy that replaces the normal blood filtering function of the kidneys. So means once your patient has a renal failure, he is unable to maintain his normal metabolic and acid base and fluid balance. You need another system to be replaced that can function as a kidney. So it is used when the kidneys are not functional. They are not functioning regarding their acid-base balance, their metabolic function, their fluid balance, their endocrine functions, and all other different functions of the kidney. So in condition like acute or chronic renal failure, sometimes patients have acute renal failure, acute kidney injury. They may have severe hypovolemia, dehydration leading to ATN and acute renal failure. Or they may have some severe septicemia leading to renal shutdown. They may have some shock state leading to reduced renal perfusion, they go to acute renal failure. So there are different causes of acute renal failure. Means that acute renal failure, either it is a temporary phase, you need to maintain the body balance like metabolic, electrolyte, acid base, for the time the kidney start functional. That is the acute phase. You put the patient on some replacement therapy and let the kidneys rest and gets back to his function. That is in the acute phase. In chronic phase, yes, you need, the kidneys are chronically damaged. These are shrunken kidneys, like they have patient have complicated diabetes with diabetic nephropathy, hypertensive nephropathy. They have other renal manifestation like chronic kidney stones, amyloidosis, the other different functions of the kidney which are disturbed because of chronic illness. So kidney failure may be acute or chronic, but once it is non-functional, kidneys are non-functioning, you have to put this system on which can maintain the normal life of the person regarding their fluid balance, acid balance, electrolyte balance, and their normal function until you go for some replacement therapy. So modalities, we have three. Number one patient who is having non-functional kidney, who has a renal failure, whether it is acute or chronic, they can be put on hemodialysis, or they can have peritoneal dialysis, or they can have, once you establish this kidney is not going to work, whether it is acute renal failure, whether ATN and kidneys are lost now, you have tried your best treatment, but they are non-functional, and then you think about renal transplantation. Or patient with chronic renal disease like diabetic nephropathy, hypertensive nephropathy, they have small shrunken kidneys and kidneys are non-functional, and you have to plan for renal transplantation. So renal replacement therapy, we have three modalities. Number one, hemodialysis. Number two, peritoneal dialysis, or renal transplantation. So these are the basically renal replacement options one can adopt to maintain the normal body function until you have a permanent solution. So dialysis, what is dialysis? So all dialysis modalities can be used to ensure the equivalent solute clearance and ultrafiltration. So there's different mechanisms which are used for dialysis. You have a solute which work as a equivalent, and you have a some filtering unit which leads to removal of your waste from the blood, like urea, creatinine, your extra fluid, and your so choice of procedure depends on the patient itself, whether what is the age of the patient, what is the size of the patient, cardiovascular status, patient with chronic renal disease, may have ischemic heart disease or may have dilated cardiomyopathy or other cardiovascular disease, and they are high risk patient one, because once you put them on dialysis, they are unable to cope with the load of the machine. So you have to think for a patient who is going to on a replacement therapy, you have to see different status of the patient. What is the age, what is the size, what is the cardiovascular status, availability of vascular status, and integrity of the peritoneal membrane. Okay, if you want to put the patient on peritoneal dialysis, and patient may had history of tuberculosis or may have history of some internal malignancy, and they have some surgery or some perforation intestine, they may have adhesions in the peritoneal membrane, and membrane is not that functional. So it is difficult to put the some fluid and have a peritoneal dialysis. So in that condition, it is contraindicated as a peritoneal dialysis. In then you have to think about hemodialysis or other modalities for replacement therapy. Like expertise are definitely available. You need to have a special units like dialysis units. You need to expertise, because putting a catheter for abdominal dialysis, for hemodialysis, you need a vascular surgeon who can make a arterial venous fistula or some shunts, or putting a central line for acute renal failure. So these are the all modalities and requirements the gene need to be considered patient who is going to be on replacement therapy, whether dialysis in the form of peritoneal, hemodialysis, or renal replacement like renal transplantation. Okay, so what are the general indication of dialysis in patient with acute kidney injury, AKI, acute kidney injury or acute renal failure? Number one, patient may have high uremia, or patient may have uremic encephalopathy. Patient is unconscious because of high urea level, that is called uremic NCAF. Like patient with hepatic NCAF because of ammonia accumulation in the brain, and patient is unconscious. So same is the uremic encephalopathy. When patient is high urea level, may have electrolyte impairment leading to brain edema, and patient need some replacement therapy like dialysis or whatever the modalities available. Hyperkalemia is another indication. Hyperkalemia, because once the kidneys are non-functional, that your filtration capacity of the kidney is lost and you have electrolyte impairment, especially hypernatremia can cause bradyarrhythmia, can have heart block and lead to cardiac arrest. So initial phase of ECG, you may have hyperacute T wave or called tentative T wave. Then there is a broad prolonged PR interval, broad PR interval, and you can have sine wave. That is a feature of hyperkalemia. And if you are in an emergency department, patient with acute renal failure, you see the ECG, hyperacute wave in generalized tall tentative T wave, you suspect this may be a hyperkalemia and ask the lab to give you urgent report of serum electrolytes, and you may find the potassium is 6.5, maybe more than that. So 5 and above can be seen on ECG, and you can depress the patient. So treat the hyperkalemia, because once you have a hyperkalemia, it can lead to cardiac arrest and patient can die because of hyperkalemia, cardiac arrest. Hyponatremia is another, I told you, is another electrolyte impairment, can lead to hyponatremia, can lead to brain edema, and when patient has fits because of hyponatremia. And fluid overload is another indication. So hyperuricemia, hyperkalemia, hyponatremia, fluid overload. Patient is unable to filter the excessive fluid from the body. Patient may be olivuric or even anuric, leading to fluid overload, may have generalized edema, may have pleural effusion, may have pericardial effusion, and patient may have acute renal failure, leading to pulmonary edema. And these are the patients who are dyspneic and need to remove excessive amount of fluid, that is through ultrafiltration or the use of special solutes which remove the body fluid. Uh, and then you have metabolic acidosis. If you suspect a patient who is having renal failure and he is hyperventilating, he is dyspneic, tachypneic, and hyperventilating, you suspect he may have metabolic acidosis. You ask for ABGs, pH is 7 or below 7. That means this patient is he is having metabolic acidosis. With sometimes these are the patients who are compensated by hyperventilation. They want to correct their metabolic acidosis by hyperventilation, by removing calcium, by removing carbon dioxide from the body. So in that setting, you have to see the ABGs and see the metabolic acidosis. The hypercatabolic state, another picture when patient have a wear and tear in the body, you have high urea creatinine, high catabolic state, patient may be septic, and these are the indication for acute renal replacement therapy when patient is having acute renal failure. For chronic kidney disease, GFR less than 15, growth failure, severe hypertension, intractable intravascular volume overload, that's fluid overload, profound electrolyte imbalance, meaning they may hyperkalemia, hyponatremia, hypermagnesemia, and other electrolyte imbalance. That is the indication for replacement therapy. Okay, the acute peritoneal dialysis. Patient who comes to you with history of acute renal failure, and the specialized unit, if they have hemodialysis or whatever the modality you want to use, is depending on the expertise available and the patient condition. So if we discuss the acute peritoneal dialysis, so you need to have ultrafiltration by excess fluid removal and diffuse transport, and that is you exchange the solutes and movements of the fluid across the semi-permeable membrane, that is the peritoneal membrane. So you put a fluid on one side of the membrane and let the membrane have its own diffusion and permeability to remove the excessive fluid on the other part of the membrane, excessive electrolytes on the part of the membrane, or let it correct by diffusion capacity of the membrane. So this is the natural process of filtration by putting a fluid which is working as a solute on one side of the membrane, and you allow the fluid to become normal on the other side, and then remove the excess fluid, remove the fluid which has been filtered out, the electrolytes and the urea content. Hello. Okay, so one is the you put a solute on the one side of the membrane, and other part is you have a diffusing transport. So solutes which are exchanged across their concentration gradient between the peritoneal capillaries and the dialysis solute that is instilled into the peritoneal cavity. So this is a very natural process of diffusion that takes place around the peritoneal capillaries, peritoneal membrane, and the instituted fluid, which act as a solute, and you remove the excessive urea, peritoneal, your electrolytes, whatever being is abnormal, that is going to be in a normal range. So this is a very simple method of peritoneal dialysis. Okay, if we go into detail, we use the peritoneal membrane as a filter, and membrane covers the body organs, and you know in the abdomen we have an abdominal wall, and membrane size is about 1 to 2 meters square and approximate the body surface area. So this is a, you can very well imagine you have a very good surface area which can act as a diffusion of solutes and the different electrolytes and the urea, creatine, or metabolic waste that should have been passed through the kidneys are within the body, and they are being exchanged through the peritoneal membrane capillaries, and solute will remove all the waste. So diffusion is a very important process. Movement of solute across the peritoneal membrane from the area of higher concentration to an area of lower concentration. So patient is having high urea, creatinine, high potassium, high magnesium, other electrolyte impairment, and you put the solute on one side and let the membrane has a diffusion that makes it a normal physiological range, and that is the diffusion area. And then you have a osmosis, movement of water across the peritoneal membrane from area of lower solute concentration to an area of higher solute concentration. So fluid is removed by this osmosis, and the electrolytes, urea, creatinine, and all these stuff is removed by diffusion capacity of the peritoneal membrane. Ultrafiltration is as a method when water removal related to the an osmotic pressure gradient with the use of various concentrations of dialysate fluid. I mean, if you have a patient having high excessive fluid retention, like patient is edematous, he's got pleural effusion, he's got pericardial effusion, he's having dyspnea, with, then you use some fluid which are of various high concentration to remove the excessive body fluid, and they are being cleaned out. So there are three mechanisms: number one, diffusion; number two, osmosis; and then you have the ultrafiltration method to remove the excessive body fluid. So fluid called dialysate, which I told you, is put into the abdomen through a peritoneal dialysis catheter. This fluid is left to dwell in the peritoneum for several hours, maybe 4 to 6 hours. And while in the abdomen, the fluid collects waste that have been filtered through the peritoneal membrane through diffusion and through your osmosis. So this is very important mechanism of diffusion, osmosis, and ultrafiltration. And this fluid, which is need to be fluid collects the waste which have been filtered through the peritoneal membrane, and these waste pass from the body when the fluid is drained out. So you have a peritoneal membrane which is going to work for you as a diffusion, as a osmosis, as a ultrafiltration area, like a filter. And you put a fluid in the abdomen, and then after 4 to 6 hours you remove the fluid from the same catheter, which is a ingoing and outgoing valve, and you remove the fluid. That is going to remove all your body extra waste. Okay, so peritoneal dialysis performed daily by the patient at home. This is very easily, but there are different complications we'll discuss later on. So it can be done at home, more physiological, and allows for independent patient can work or travel. You have early morning wake up, you put the fluid in your abdomen and through your catheter, and you go to work. After 6 hours, you can remove the fluid by outgoing catheter, and your body waste are removed. Very simple diffusion osmotic method. Fuel fluid are dietary restriction. Okay, this is one of the advantage of peritoneal dialysis. Patient can have normal fluid if you have excess, you think you have a gained weight. These are the patients who usually do their weight every day, and they see if they have gained weight, there is some extra fluid in the body. They use the solutes which are hypertonic and remove the fluid. And you can have some dietary uh, liberty. You can use the protein sometimes, some fluid, some diets which are restricted in chronic renal failure. So you have a solution of peritoneal dialysis. You can have a good diet and remove all the nitrogen wastes. Same is peritoneal dialysis offer a few medical or low dose doses are required. So very few medications are being used. Otherwise, patients who are renal transplant or other modalities, they need to have immunosuppressive drugs or to prevent the rejection of the kidney. So we'll discuss later on. So this is a simple method. It can be performed at home. It can have a independence of dietary. You can have a normal diet, and according to that, you can manage your fluid and nitrogen waste removal. And very few medications are required. Residual renal function preserved. Whatever, if you have a renal function like GFR around 20-25, that can be maintained on below 15 is end stage renal disease, but patient have 30 GFR can be maintained on that basal level. And Ministry of Health fund home therapy. This is not in part of the world, but in Europe or other welfare states, they give you facilities. If you are working, if you have some agency which is involved in your health, they give you support in that respect. Okay, so patient with peritoneal dialysis must have a clean room to perform exchanges and a large enough area to store all supplies, because you need to restore a lot of solutes into your home, because once you do at home, you can have 3 or 4 sessions, and you need to have a clean area. There should be no risk of infection at all, and no pets allowed in the room. That is, they can carry some infections, some allergic reactions, and that should be a very clean area without any source of infection. Must learn to monitor their own weight and blood pressure. This is, I told you, very important. Patient should weigh itself. If they think they have gained 1 kilogram and probably it is fluid retention, and they can use the solute to remove the extra fluid. So this is a very educated style of cleaning their kidneys. They're cleaning their waste from the body, and must be able to follow important instructions to prevent infection in the peritoneum. So this is a very, very important part in patient with peritoneal dialysis. The risk is peritonitis infection of the peritoneum. Once it is there, it can be very dangerous and can be lethal for the patient, and you can lose your peritoneal membrane that has been functioning for you as a diffusion area. So must also be able to determine the choice of dialysate fluid and when to use it. So this is, again, I told you, patient that have a different electrolyte impairment, they can do different solutes, and or they can if they have a excessive fluid retention in the body, they can use a dialysate to remove the excessive fluid. So it is basically patient are being trained for their peritoneal dialysis at home, how they are going to perform it, and what is their area where they do their exchange and of fluid, and it should be clean, and all these instructions should be followed. This is a most widely used polyethylene car catheter, which is available all over the world. And I have been working in Shedda hospital. They used to do this catheter for peritoneal dialysis. And this is the chronic dialysis catheter, which is being put in, and you use as a installation of fluid and drainage area. So this is the basic technique or principle of peritoneal dialysis. You can see the peritoneal membrane is all over the abdominal line, and you put a catheter is here, you put the fluid in, and let the membrane function. It's a diffusion and the osmosis function, and let the so you put the fluid bag there. This is the solute, which is solution bag, You open the catheter and put the fluid in the peritoneal cavity. It is all stay there, and after few hours, 4 to 6 hours, to let the patient have its complete diffusion and osmosis, and all this process takes place, and you remove the fluid through a drainage bag. So this is very simple, but you need to be very intelligent in that process. This is the patient undergoing peritoneal dialysis. There is a continuous ambulatory peritoneal dialysis. The patient comes to his room, have a session of 4 to 6 hours, and goes out. Or sometimes they instill the fluid and keep their activity, and after 4 to 6 hours they come back in the room and let the fluid drain out. So this is a simple method of who can use the exchange of this is your dialysis the fluid. It is going in your peritoneal cavity, and it stays for a few hours. This is the indwelling catheter which is being used, and then you have a drainage bag which can be removal of fluid with all waste from the body. So peritoneal dialysis solutions are currently available, which are usually dextrose based. So they contain dextrose as an osmotic agent, and non-dextrose containing solutions reduce the risk of hyperglycemia. So this is the some basic technique. Dextrose solutions are used. Other solutions commercially available are lactate, sodium, and calcium solutions. Okay, type of peritoneal dialysis can be CAPD, that is continuous ambulatory peritoneal dialysis. The blood is cleaned constantly by dialysis fluid while it is in the abdomen, and the patient doesn't need to require the use of machine, exchange, and completed it is manually. Automated peritoneal dialysis requires the use of machine called a cycler. A cycler is used during the night and set to deliver the fluid in and out of the abdomen. This is like a you have a controller that a cycler which let the fluid go in and when you are sleeping, and after 4 hours it automatically opens the drainage area and let the fluid come out of the abdominal cavity. So this is the new modalities which are being used, automated peritoneal dialysis. Indications, I told you, the patient who had some bleeding tendency, you cannot go for hemodialysis. Patient is very hypertensive, cannot tolerate the dialysis machine, and patient who have a diabetic nephropathy, in that patient who it is easy to go for peritoneal dialysis. And complication, very important, peritonitis, infection of the peritoneal membrane, injury of the viscous. Sometimes when you insert the catheter in, it can cause some intestinal laceration or some injury to the internal abdominal viscera. And abdominal hernia is one of the localized complications, and leakage of dialysis into the peritoneal cavity or scrotum. So this is one of the another complication. So these are the usual complications, and in the initial slide we discussed what are the basic requirements. You need to have a clean education of the patient is very important. You should know what is the peritoneal dialysis and what precaution I should take to prevent the infections, prevent the visceral damage, prevent any abdominal hernia or some other leakage of the dialysis. In patient with a chronic peritoneal dialysis, accepting mode of treatment of patient is usually waiting renal. It is a very simple technique. Patient who has to wait for the chronic renal replacement therapy like renal transplantation, or your dialysis machines are not that freely available. So you can use that peritoneal dialysis technique. So CAPD has discussed continuous ambulatory peritoneal dialysis, and it has a plastic bag containing dialyzed fluid and transfer set and a permanent peritoneal catheter. And then you have complication already discussed. Patient with this procedure are particularly suitable for infants and for small children, and because hemodialysis, all the techniques are very difficult, and you can use these simple measures at home. Complication discussed, it can lead to peritonitis, catheter malfunctioning, abdominal or hernia, backache, hydrothorax, or some respiratory difficulty. Continuous cyclic peritoneal dialysis, as we discussed it as a most common approach, involves frequent continuous cycling of the dialysis during the night while the child is asleep or adult is asleep, then leaving in a small volume of dialysis during the daytime. So this is a very controlled method of peritoneal dialysis at night, and automated devices minimizes the need for excessive manual manipulation and hence reduces the risk of peritonitis, and the patient can carry out day-to-day activities and attend the school. So this is a very good method of having using the peritoneal membrane as a filter for the body, and like an artificial kidney, like an alternative to kidney in children, especially who are can be managed on peritoneal dialysis. So advantages: ability to perform day dialysis at home, technically easy than hemodialysis, especially in infants, and ability to live a greater distance from the medical center, which you can perform at home. Freedom to attend the school, the child can go to school and come back with the overnight dialysis, and one should maybe process during daytime. Less restrictive diet, patient can have liberty of diet and less expensive than hemodialysis. You don't need any expertise, you don't need any machine which works for you as artificial kidney, and you don't have to go to a medical center for dialysis. Disadvantages we already discussed: catheter malfunction, catheter infection, impaired appetite, negative body image, or some social factor is there. You are on peritoneal dialysis. So that was a simple technique. Now we come to the more sophisticated and area, which is the hemodialysis. So in this technique, we directly use our blood that is passed through an artificial kidney, which has two components, that is blood dialysate and that separated by thin semi-permeable membrane, same like peritoneal membrane. And this filter has a thin semi-permeable membrane, and from one side blood is put into the filter and it is removed from the after being rotation and filtration, and the waste is removed, and I'll show you the dialysis machine how it works. So waste and excess water pass from the blood side to the dialysis side and is discharged and is discarded in the drain. The clean blood return to the patient. So this is a simple method. You have a waste and excessive water which is passed from the one side of the dialysate in the blood, and the other side it is being drained out uh, clean blood to the return to the patient. So one process of blood is coming out of the patient, filtering through a filter and coming back to the patient, that is a normal filtered blood with a removal of all its wastes like nitrogen waste and everything. Usually it is done 2 to 3 times per week and 4 to 6 hours for each setting. So it depends on the catabolic state of the patient and his residual function capacity of the kidney. So twice a week is usually done, depending his renal function status. So hemodialysis treatment is every other day or not as a physiological compared to dialysis. Requires a trip to the hospital for 2 to 3 times per week. Patient can travel to other units but must be arranged and space is not always available. So this is the very dependent part of the replacement therapy, which is hemodialysis. You need to have a specialized unit. You go to a center and have your session done for 3 to 4 hours, and you come back at home. So it is all your availability of dialysis machine, your how busy the center is. So you need to wait for your turn. Patients have more restricted diet and fluid intake between the treatments. So as compared to the peritoneal dialysis, where you could take food and liquids, but here the patient on hemodialysis, they have a more restricted diet and because if they are dependent on a machine, if they excessive amount of like proteins and liquids, and they may require every other day dialysis. So this is, you need to maintain your basic metabolic and catabolic state of the body to a minimum level. So you don't need to go for frequent dialysis. So medication required different from those of the peritoneal dialysis. Usually these are the patients who are on antihypertensive, they need the medication, and sometimes usually they have a anti-diabetic treatment, and the dose of extracortin is very, very important. I told you these are the patients who are being given subcutaneous extracortin once or twice a week to maintain their hemopoietic system, to treatment for renal failure with anemia. So principal hemodialysis are basically the same as for peritoneal dialysis. It is a ultrafiltration. You can remove the excessive amount of fluid, and solute removal by connective transport and diffuse transport. So this is the same as a peritoneal membrane, and you have an artificial filter, which has a same diffusion and osmotic function and removal of the excessive waste from the body. Okay, hemodialysis and peritoneal dialysis, but how would you differentiate? I see that the driving force between the two processes is the same. Sorry, the differences, and number one, the driving force between that process. Number three, technical aspects of the procedure, and number three, duration requested the treatment. So peritoneal dialysis is much cheaper, easy. You can perform at home. You don't need to go for medical centers. You don't need any extraordinary machine. It is a simple technique. For hemodialysis, yes, you have to have a proper dialysis unit. You need to have a more expertise, and sometimes some hypertensive cardiac events can take place. Patient can, if you excessively remove the fluid, patient go into hypovolemic shock, and there are different complications which can take place during the hemodialysis. Mechanism, again, what happens is you take an arterial blood pressure, and you take a fluid from your body, and this is the blood which is taken out. It is being pumped, and through a filter it passes. This is the dialyzer, and this is the dialyzer. This is the basically the unit that is called artificial kidney. So you take the blood from your body and put in a blood pump that is pushed through by force to a dialyzer, and then it, after cleaning, after this diffusion and osmosis and filtering takes place, it comes back to your blood and being entered into the body. So this is another way of artificial kidney. You have a peritoneal membrane, and now you have a filter. Okay, the rate of transfer of substance depends on the surface area and the permeability of the dialyzer membrane, the solute concentration gradient, and the rate of blood flow and dialysis flow, and composition of the dialysate. So this is the technique of hemodialysis. Excuse me, let me check. There is some other voice coming out.
And here it releases the trophozoites. Trophozoites are formed in the cyst and releases trophozoites. These trophozoites can cause the invasion of the
कोई और लेक्चर आ रहा है दरमियान में?
And this is the reason of presence of blood in.
Okay, so there was some interruption. There was another lecture which was being put on. Anyway, so this is the rate of transfer of substance. It depends on the surface area and the permeability of the dialyzer membrane, the solute concentration gradient, rate of blood flow, and the dialysis flow. So this is very, you have a pump which push the blood into the dialyzer, and then blood comes back. यार दो लेक्चर को मिक्स हो रहे हैं, चेक करो. Okay, so there was some interruption. So this is basically the substance which is being transferred through a pump to dialyzer membrane, and then you have a different solute concentration which acts as a gradient and rate of blood flow and dialysate and the disposal composition of dialysate. So what are the vascular excesses which are being used? You can use a arteriovenous fistula, you can use AV graft or tunnel cuff catheter. So these are the three techniques which are being used to take blood from the body and being passed to the dialyzer filter and then comes back to the body again. So after a circle of blood from your one circle goes to the body back and you have a filtered blood. So this is a simple dialysis unit with the hemodialysis machine. You can see the this is the filter. Basically, from one end the blood is being pumped. This is a pump which pumps the blood. It is a pump which pushes the blood into the dialyzer, and after being filtered out, the blood comes out and goes back to the patient. This is the patient line where the two way, one is the coming out blood and passing through the pump, going to the dialyzer and coming back to the body again. So this is the normal process how this hemodialysis takes place. This is another view. There are two catheters you can see. One is the outgoing, going to the machine through a pump, coming being pushed blood to a dialyzer. This is a dialyzer filter, and you can have blood being filtered and cleaned out and coming back to the patient. And this is a patient on a hemodialysis again. Incoming blood through a filter and outgoing going to the back to the patient after a filtration. Okay, so hemodialysis requires access to the bloodstream. Either you use arteriovenous fistula, either use the venous graft, or temporary catheter or long-term catheter. So this is a different modalities how you can remove the blood from your body and you have access to the machine and then goes back to your body. So this is the arteriovenous fistula which are being made by a vascular surgeon, and that needs maturation about 6 to 8 weeks. So if a patient on renal failure like chronic renal failure, you see his GFR is falling down and they're going to require hemodialysis or some renal replacement therapy. So you early plan for arteriovenous fistula, send the patient to a vascular surgeon, and he can perform arteriovenous fistula that needs to be mature for 4 to 6 weeks or maybe 3 months, and then you will be able to have your blood access from the body. So this is the simple hemodialysis fistula, and this is the arteriovenous graft. One graft is being put and it is attached to the vein and then to the blood. So this is the continuous blood flow keep on coming from the artery to the vein, and you have a shunt here, and this is how the graft is being made, and you can use the venous side, and that is your blood will be taken from your venous side. It will go to the machine and come back to the artery. So dialyzer and the blood tubing. So most dialyzer currently are hollow fiber dialyzer. Most modern dialyzer are made up of modified cellulose or entirely made of synthetic material. So advantage of being more permeable and efficient solute removal. So this is a specialized filters which are being used for hemodialysis, and the choice of dialyzer is based on the size of the dialyzer. And then you have a length and frequency of dialysis. The main aim is for the 30% reduction in BUN creatinine in first dialysis in 1 to 2 hours, and then 50% fluid, 50% removal during the next 3 hours, and more than 70% reduction during subsequent treatment. So this is the how body waste and nitrogen waste are removed from the body. Complication during dialysis can takes place, that is dialysis disequilibrium syndrome. This is the long-term dialysis can lead to brain memory loss, and patient can be confused, disoriented. That is called dialysis disequilibrium syndrome. Manifested, even patient can have fits because of the brain cells edema and some different accumulation of waste that during dialysis can take place, and the patient can have fits. That is called dialysis equilibrium syndrome. And muscle cramps, hypotension, nausea, and vomiting and itching. These are the complications which can take place during dialysis. Advantages, yes, maximum solute clearance. You have a very good filter which can be used according to your urea creatinine, your electrolyte imbalance, and acid-base status of the patient. And best treatment for severe hyperkalemia. So if you want to remove the patient potassium, which is maybe more than 6, and you have a risk of patient going to cardiac arrest, and some toxins are even removed by the special types of filters. And readily availability, yes, if you are in an area with dialysis units are available, and you go to the center, have a 3 to 4 hour session, and come with your removal of all the nitrogen waste. And limited anticoagulation time and bedside rescue access. Disadvantage of hemodynamic instability can take place. Patient can have hypoxemia, that is some pulmonary or other complication. Rapid fluid solute shifts and complex equipment. Definitely, it is a machine. There may be some technical errors or some other problems. And specialized personnel need to be a staff which is trained for hemodialysis, and difficult in small infant because babies are not that cooperative, and they are afraid of going to hospital, and they don't have a they can't lie for 4 to 6 hours in a bed just waiting for the machine to work and remove the waste. For children, it is better to have a peritoneal dialysis. Continuous renal replacement therapy. Okay, variant of hemodialysis therapy. These are continuous and prolonged for days to weeks. So there are two types are used. Either it is a continuous veno-venous hemofiltration. So this is a new techniques like as we discussed, the continuous peritoneal dialysis overnight through a operate through a machine, not through a like a pump which can be used at night. But this is the continuous veno-venous hemofiltration, only connected transport without adding the dialyzed compound. So this is the advanced technology. And continuous veno-venous hemofiltration dialysis, dialytic compound added. The choice of continuous veno-venous hemofiltration or continuous veno-venous hemofiltration dialysis is center dependent, and also on the need for solute removal. That's usually greater in. So if you have a hyper volemia, your fluid excess in the body, the continuous veno-venous hemodialysis is more effective, moving the through filtration technique. So indication for continuous veno-venous dialysis, the modality of choice in patients who are critically ill and hemodynamically unstable patient, neonates, infants with cardiovascular or abdominal surgery, trauma, shock, inpatient shock and multi-systemic failure, and children with inborn error of metabolism such as urea cycle disorder. So these are the different techniques which are for specialized children and adults. So disadvantage of this technique, same as seen in hemodialysis, continuous nature. It is a continuous process which is taking place, and great risk of different complications, and continuous vessel access, very close monitoring, and very expensive. So this is the temporary hemodialysis catheter. You can see the central JVP line and double lumen catheter, which is being put here through the internal jugular vein, and that is going to work for dialysis. So this is the how you put the central line double lumen catheter and go for the hemodialysis. So what are the indications of hemodialysis? Acute renal failure, chronic renal failure, hyperkalemia, hypercalcemia, toxicity, and severe temperature disorders like patient with other like temperature disorders can be a candidate for hemodialysis. You need to have a AV shunting complication, like patient can have arteriovenous thrombosis, can have aneurysm formation, infection, and patient can have heart failure even, because once you have a arteriovenous shunting, there is a continuous mixing of blood from the arterial shunting that lead to high output cardiac failure. So these are the patients who are long term can be go into high output cardiac failure. Bleeding tendency, yes, if you have some localized trauma can lead to excessive bleeding. Complications of getting infection like hepatitis B, C, although there are different machines which are allocated for hepatitis patient like B patient, B machine, C machine, non-B, non-C, or other for patients which are having no hepatitis B or C. Loss of follic acid and B complex and hormones, dialysis, disequilibrium syndrome at all. Can you have a mental disturbance? Even fits can lead to fits can occur because of dialysis equilibrium syndrome. Dementia. This is a very if you long-standing chronic renal failure with patient on dialysis can lead to dementia due to chronic dialysis using hard water to dissolve the dialysate. Hypertension, yes, shock state, air embolism, and depression. So patient can think now on a machine which is working for my kidney, and he has to go to 2 times a week for hospital for dialysis. But these are the very depressive attitudes which need to be looked after in patient on hemodialysis. Okay, so third option in that if a patient who has a non-functional kidney due to some acute insult or some chronic disease can have peritoneal dialysis, can have hemodialysis, and lastly, patient who are recipient who have a good donor which have a ABO and HLA compatibility, they can have depending on the donor and that renal transplantation. That is a normal kidney which can be taken from a donor to the recipient. So renal transplant is the option which is nowadays secured and very successful. And what are the techniques which are being used? Basically, you have a source. So living either related donor with HLA and ABO matching. So this is the ideal. If you have a related donor with the HLA ABO matching is the ideal. An unrelated donor with HLA with partial matching and cadaveric kidney. So these are the different options and techniques which need to be there for renal transplantation. So what you do is you do a nephrectomy and the kidney is perfused with cold solution till the transplantation ischemic time is achieved. And like patient with the cadaveric kidney, there is some accident, some patient acute death, and you have a consent for renal transplant, and you can go for emergency transplantation. The kidney is placed in iliac fossa and anastomosed to iliac vessel, and ureter is placed in. So this is a simple technique, taking the iliac vessels and putting the kidney in iliac fossa, and you have a attached with a catheter at the ureter. And naturally, your bladder is functional, and you have a blood from coming from one iliac vessel filtered through the kidney and through the ureter, and you have bladder. So indication: all patients of end-stage renal disease without contraindication for transplantation and with available donor. So this is very important, because human organ transplantation, there are different agencies which monitor these modalities, and especially the renal transplant is now very officially being done, and it has a best if you have a donor which is the HLA and ABO matched, and you have a recipient which have a chronic kidney disease. Okay, common complications of transplantation. Early complications are surgical complication, delayed or slow graft function, and lymphocyte. So these are the few complications which are early. The later on complication, allograft rejection. So this is the hyperacute rejection, the antibody being mediated rejection within minutes to hours of perfusion of the allograft. So this is a very acute rejection, and sometimes this is a chronic rejection. So due to performed antibodies to ABO and HLA antigen, acute rejection can take place because of some antibodies which are preformed, and they react and cause acute rejection of the kidney. And acute rejection within 3 months of transplant. So acute means if you have a hyperacute rejection within hours, then you have acute rejection within 3 months, and then you have a chronic rejection after 3 months. So allograft rejection either hyperacute because of the antibody rejection, acute maybe some other rejection reasons, and chronic rejection can take place after 3 months. Infectious complication like CMV, these are the patients who are being risk of having infection like CMV, other viruses, and buckets, hypertension, diet therapy, ACE and crunch and calcium channel blockers are being used, and hemodynamic complications like anemia, leukopenia, thrombocytopenia. So these are the being looked after in patient with the renal transplantation. Metabolic complication, hypomagnesemia, hypophosphatemia, hypercalcemia, and all these dyslipidemia, malignancy post-transplant, lymphoproliferative disorders, and recurrence of primary disease in allografts. This is the very problem patient with like patient long-standing diabetes, long-standing other chronic diseases or autoimmune diseases, they can damage the kidney itself, and chronic allograft dysfunction. And then other surgical complications like lymphocyte, perianal, serous fluid collection, hematomas, graft thrombosis caused by thrombosis, the donor renal artery or vein, usually happens in first week. So they are diagnosed by ultrasound and Doppler study. If you have a acute renal rejection, or there is some thrombosis or renal artery, that can be seen on Doppler flow study. There is lack of blood flow, and there is a turbulence of flow that can be seen on Doppler study. Almost always require a plant of kidney. Basically, this is the patient who are recipient of the kidney. They need to be looked after for hyperacute rejection, acute rejection, chronic rejection, and other complications which can take place. So need to be under care of a specialist. Okay, the patient who are being donated kidney, the recipient need to have a blood drugs to prevent these rejections. Like immunosuppressive medications are required to prevent the rejection of the kidney. Uh, induction therapy use corticosteroid, antithrombotic, antithrombocyte globulins, ATG, and sometimes intraleukin receptor antagonist. So these are the acute inflammatory and acute rejection procedures are being rejected by immunosuppressant medications. And maintenance are usually made on patient on long-term corticosteroid, sometimes on calcium inhibitors to prevent the rejection problem, and motor inhibitors and anti-metabolites. So these are the different medications which are being used in patients who have received the renal transplant, and they are prevented from having rejection problems. So thank you very much. This is all what we have renal replacement therapy. Renal replacement therapy means once somebody's kidneys are non-functional, and you need some other way of your body balance, like nitrogen, removal of nitrogen waste, your electrolyte, your acid base status, your endocrine function of the kidneys. So all these are being managed by the different modalities which are being used until the patient go on to renal transplant. So for temporary phase, you can have peritoneal dialysis and hemodialysis, and then you could plan for renal transplantation. So this is the what are the sources we have for patient who have renal failure, and that is the renal replacement therapy. Okay, thank you very much. I think I have tried my best to just let you know what are the modalities available, and you go and read your subject, and wish you all the best. Thank you very much. Allah Hafiz.